is kind of a low energy Thursday, but thank you to everyone who has logged in so far, and welcome to our MRF HIV STI Echo. I am Dr. Gregory Boyce. To my left is Dr. Miriam Parboo, who will be giving both the didactic and the case presentation today about trichomoniasis, which I think is one of those STIs that is kind of, I wouldn't say neglected, but maybe not given as much attention as chlamydia and gonorrhea and all those other things. But we kind of forgot about trichomoniasis. And it's a really interesting case. She presented it before, and there's a follow-up. I remember we were really scratching our heads trying to figure out how to solve this case. And she came with a brilliant solution. So it's really exciting. At least I find it exciting. So strap in, and remember, it is meant to be an interactive session. So ask questions, put up your hand, interrupt if you need to, so we can learn as much as we can. So I shall turn over the floor to Dr. Parboo, and I'm going to start sharing the screen so she can get started on her presentation. And here we go. Dr. Parboo, over to you.
Hi, good afternoon, everyone. I'm Dr. Parboo, and as Dr. Boyce mentioned, we're going to be talking about trichomoniasis today. Right, so it's a sexually transmitted infection caused by Trichomonas vaginalis, and it is curable. So it's really important that we identify it wherever we can when a patient is symptomatic, or if it's picked up on screening, and treat it to prevent any further complications. Right, so it's a pear-shaped flagellated protozoa, right? There are 4 to the front, 1 to the back, right? It's 9 by 7 micrometers, and it's motile, and they thrive in pH higher than 4.5, which is higher than the normal vaginal pH. The risk factors would be sexual contact with an infected partner, new or multiple partners not using barrier protection, and other STIs being present. So in the Caribbean and in Trinidad and Tobago, we have very little data on trichomonas infection, right? So there's definitely a need for research in this area. There was a study that was done in 2018 in Trinidad, and they looked at a group of 422 females in an STI clinic, and they sent the vaginal swabs. They did wet mount, microscopy, and culture, right? And they found that 16% did have trichomonas, right? So it is around. When we see clients, we don't always test for it, so it could be why we're not picking up as much, right? So keep it in the back of your head that any person that comes in with a discharge, we need to think about trichomonas. So presentation in females. Now you can be completely asymptomatic, and then you can have severe pelvic inflammatory disease. So you want to look out for things like an abnormal vaginal discharge, right, which may be purulent, frothy, bloody, abnormal odor, vulvovaginal itching, burning, soreness, painful intercourse, painful urination, postcoital bleeding, and lower abdominal or pelvic pain, right? You also need to think about a cervicitis. So when you're examining the patients, you want to see if you're seeing a lot of discharge coming out from the endocervical canal, and you want to see if the mucosa is easily friable. So you want to see if it's bleeding very easy when you're touching it or very red, right? And you may be able to see punctate hemorrhages, colpitis macularis, or strawberry cervix as seen in the photo to the top. In males, it's the same thing, can be completely asymptomatic on one end of the spectrum, or you can have a urethritis, and sometimes even it could branch to inflammation of the prostate as well. Men are more likely not to show any symptoms, and their body deals with the infection faster and resolves it than women, right? And non-gonococcal, non-chlamydia urethritis is the most common symptom reported by men that do have trichomoniasis. So any male that is coming to you with a urethritis, you must think about trichomonas. So they may have discharge, difficult urination, they might have itching by the urethra, pain by the urethra, they might have testicular pain, and they may also complain of lower abdominal or pelvic pain, right? And the symptoms could be intermittent, and it's usually self-limiting with men. Complications. So in women, you want to think about the risk of pelvic inflammatory disease. When you're examining them, you should always try to see if there's adnexal tenderness or cervical excitation, right? And you want to treat those things properly. there's a 1.9-fold risk of tubal infertility in women, right? And it could play a role in cervical neoplasia and post-operative infections. But we don't have too much information on that. Pregnant women also, they are at high risk for adverse outcomes. They could have low birth weight, preterm delivery, intrauterine infection, and Trichomonas also increases the likelihood of HIV transmission because of the disruption with the vaginal mucosa. In terms of diagnosis, we tend to do a lot of wet mount microscopy, and this is because it's quick to do, it's inexpensive, and cost is very important in our setting. However, it is only 36 to 75% sensitive compared with culture, and it depends a lot on the person that is actually doing the microscopy. So you just collect a swab, you try to go in the vaginal fornix, and you place a small amount of saline and you look at it under the microscope, and you're looking for the classic look that Trichomonas has. Now, before a lot of molecular testing came out, culture would have been the standard for TB. It is more sensitive and specific than microscopy. It is very useful where there is resistance because you can find out the drug susceptibility of the strain. The disadvantage, however, is the time, and it's not readily available. And of course, now the gold standard we have would be the molecular testing. There are a few that is FDA approved for diagnosing Trichomonas, and all of them have a sensitivity greater than 83%, right? Except for the AFUM, which is a bit lower, is 63%, and a specificity of 97% for detecting Trichomonas in vaginal secretions, right? You can also send off urine as well. The expert is the only FDA approved for diagnosis in men. However, the CDC does say that you can use the aptamer with male urine or the urethral swabs for them. Right. So nitro-imidazole drugs, they are the mainstay of treatment for trichomoniasis. And there's reduction of the nitro group on the antibiotic by the nitro reductases that make it susceptible to bacteria, right? So there's formation of highly reactive intermediates, and they would disrupt the DNA, which eventually would lead to cell death. The CDC has 2 drug schedules. You can do a single dose of the metronidazole, tinidazole, or secnidazole, or you can do a schedule of 500 milligrams of the metronidazole twice daily for 7 days. Each one would have different advantages and disadvantages, but ultimately the cure rate is the same. So in 2003, there was a Cochrane review with metronidazole and tinidazole, and they did say yes, they are both around the same in terms of treating and curing effectively trichomoniasis. There are also trials comparing the 2-gram single dose with the metronidazole and tinidazole, and it also backed it up saying that it was equally effective. Now, tinidazole is more expensive, which is why we would tend to lean to the metronidazole in everyday treatment of trichomoniasis. And the cure rate that is expected with the dosages described is 95%. Also, in terms of side effects, tinidazole is generally more tolerated better than metronidazole. However, not all studies did agree with this, but in terms of patients reporting that have been on both, they tend to like being on the tinidazole more in terms of the side effects. Now, the advantages of the single dose therapy with either one over the week long is definitely going to be compliance. However, the week-long metronidazole schedule is more effective in treating HIV-infected women. So when we are treating TB, the men, I tend to do a 2-gram single dose, but in the women, I would do a week-long treatment. And it's important to know because sometimes you're talking about partner treatment as well. And you can explain to the patient why the treatment would be different. Topical medications are not recommended by the CDC, however, they can be used in conjunction with the oral treatment. So you can do the vaginal suppositories as well as the oral with the same drug. And of course, it's not recommended only topical because of the low cure rates. Right, so resistance. Resistance is rare, and you can solve it by increasing the dose or switching to another metronidazole. The metronidazole resistance is about 4 to 10% of cases, whereas tinidazole is only around 1%. So most of the time, we'll be able to effectively treat TB with these drugs. There are incidents reported of resistance to both to metronidazole alone, but then tinidazole would have worked. When standard treatment regimes fail, you can do an increased dose of 2 grams of either one, and you can do it for 5 days. You need to monitor urine and the patient's hydration status, and if they're having any complaining of any increased itching and things like that. You can also consider if oral therapy is failing IV therapy. And again, this has to be monitored pretty closely. With the case that was presented, we did do IV therapy. We didn't do it in an inpatient setting, but the client, she was actually a nurse. So we were able to work with her. So again, it also depends on the patient. It's a team effort, and the patient's baseline education is very important in terms of treating them effectively. And of course, you should do testing to see which drug will work if treatment is failing, because you need to identify resistance. However, in our setting, it's not something we're always able to do. Alternative treatment. So with this client, she did fail metronidazole orally at the normal dose. She did fail tinidazole orally, and she also, before trying tinidazole, she failed IV flagyl. So for her, it became very apparent that we needed to start thinking outside of the box and looking at alternative treatments. A lot of the alternative treatments, the most popular would have been the paromomycin cream and also boric acid. So there were a few cases, because it's not very common, the resistance. So there are a few cases that we could have looked to. There was a case of trichomoniasis that was resistant to metronidazole, and they did intravaginal paromomycin, and it worked. They did 250 milligrams vaginally for 5 days. And this was a patient that failed both metronidazole and tinidazole. There was another study conducted, and there were 9 patients, all had TB that was confirmed by appropriate testing. 4 had strains that were metronidazole resistant. 5 were allergic to metronidazole, so alternative treatment also comes into play in terms of allergies. And the treatment was done with the paromomycin cream, 250 milligrams, and they were doing it at night with the applicators. And this was done for 2 weeks. 6 of the 9 women were cured. The thing with paromomycin, however, is the side effects. They were frequent vulvovaginal adverse reactions in terms of irritation of the lining of the mucosa and even ulceration. So for me, this wasn't a favorite, because I would have been thinking, this is a client, she's had TB for a while, she's frustrated, and the last thing we want to do is try an alternative treatment with high side effects, and it doesn't work, and there's ulceration, which would cause pain and decrease her quality of life. There were also other case studies where the paromomycin did fail to treat symptomatic TB infection. And they did try acidification with boric acid intravaginally for 2 months, and they did see full cure. 2 case studies show that vaginal acidification with intravaginal boric acid for 1 and 5 months in 2 patients who tolerated this therapy. So both patients basically got the 600 milligram dosage. However, the length of time that the treatment was given varied, because one needed it longer to achieve full cure. So it was decided that we would do the boric acid, 600 milligrams, with clotrimazole inserted PV daily. And the aim is to continue this for 2 months with tests of cure performed at 3, 6, and 8-week markers. Boric acid is very inexpensive. It's minimal side effects. We have it here in the country as a loose powder. You can't really find it in all pharmacies, but certain pharmacies do have it, and you get it as a loose powder. How they would have done it for their case studies is that they would have used a gelatin capsule. We didn't really have access to that, so we decided that we would mix it with the clotrimazole. Clotrimazole is not approved specifically for use of TB. However, with the case studies, case by case, it was shown to reduce some symptoms and reduce the risk of superimposed yeast infection. Now, the final cure would not be attributed to the clotrimazole, but rather the vaginal acidification process. Also, bearing in mind the boric acid was a loose powder, we had no capsules, so it was a method of trying to mix it to get it in to be able to give PB. She reports that the discharge is cleared. This was on day 7. She has currently finished a 3-week course, and we will be going to 2 months, and we will do a test of cure, make sure we're not seeing any trichomonads, and if possible, as necessary, we may extend past 2 months, because as I was saying before, there were some cases where they did have to go up to 5 months. So the idea is to make sure that she's fully cleared and to do checks later on. She's tolerating it pretty well, and she's very happy that she no longer has a discharge. Very important in these cases of resistant TB, it is a multidisciplinary approach. You need to have a lot of persons on board discussing this type of case, right? We did speak with the social worker, the pharmacist, our infectious disease specialist. So a lot of persons were involved, laboratory technician. So it was definitely a group effort in terms of getting her to this point. And we really hope that at the 2-month marker, we are not seeing any trichomonads and that she remains negative. And those are just the references. A pretty good study to read up would be the one that was done in Trinidad with the prevalence, clinical features, and diagnosis of Trichomonas vaginalis. It was actually done QPCC, the South RHA, Northwest RHA. It was a good effort. And I think we definitely need to aim to doing more studies like this, because we really don't have a lot of information specific to our population. Right? Thank you. Does anyone have any questions?
Okay, thank you, Dr. Parboo, again for that synopsis and that clinical update. And so if anyone has any questions, you can either unmute and ask right away, or if you can't speak where you are, feel free to enter type of questions in the chat box, or you can raise your hand so we can call on you. Now, while everyone is sort of getting warmed up, do we have a source? Do we know how she got infected? In terms of partner follow-up and tracing this?
Right, so she did admit to having one sexual partner. He is denying any symptoms, and she hasn't had any partners since. So right. Yeah, so I do think that would have been her contact. When he was asked about it, he seemed like he didn't really care, and he was quite I don't know, he wasn't quite forthcoming with his information. So I just felt like maybe he did know that he had infection and just didn't want to see anything, if I'm being honest. Because even when we were thinking about getting the intravaginal tinidazole to do it concurrently with the oral tinidazole, and we reached out to him, available in the country, he kept denying that, he doesn't have anything and things like that. And then he would have, after we started to see success with the treatment, he was actually asking if we could send treatment for him. So I think he does know, but I don't think he was quite forthcoming. Maybe he wasn't comfortable with us, or I'm not sure what his reason was. But I believe that's the source.
And he's in the country or out of the country?
Out of the country.
Has he followed up anywhere?
Not as yet. I did recommend that he go and get screened, that sort of thing. But he has not as yet.
Okay. And in terms of the 2-month mark, you would decide if you're still in treatment based on the test of cure, or just going to continue going? So if she's negative for 2 months?
If she's negative, we do have the option of stopping the course there and bringing her back in 6 months swabbing again to make sure that she is negative. Basically, we're patterning it after case studies that were done before. Or we can continue for a full 5 months. Bear in mind, there are two trains of thoughts for this right now. For me, she came to us recently, but this has been going on with her since 2020. She's daily doing vaginal insertions. Before that, she was putting in IVs. Before that, a lot of oral medications. I think she's quite frustrated. I'm trying to do a 2-month course to see if it will work, but there's no way to say for sure that the vaginal acidification for 2 months will be enough. So because it's a tiresome process, we're leaning towards taking a break after 2 months, so long as all the checks, the markers are negative, but then we still have to bring her back and make sure that it didn't come back. Because some cases, they did it for a month, they were negative on the test of clearance was good, right? And then a few months later, they became symptomatic again. There were some that did longer courses, for example, a 2 months or 5 months, and then everything was negative at the checks, brought back in 6 months' time, still negative, and they even brought back somebody else up to a year and they were still negative. So it's really to kind of follow up and make sure that it's fully cured. So it's not an exact science, but we will work with her and try to keep up with the follow-ups to make sure that we have cleared it fully.
And we still have a good idea as to why she may have been resistant in terms of previous antibiotic exposure.
Right. So she did have a lot of exposure to metronidazole. It was actually every month for 2 years, right? And it was honestly poor management. There was no indication for her to be getting metronidazole, but it did happen. So that would be a main risk factor for that with her. It would have been nice if we could have done the susceptibility testing to actually see, metronidazole, tinidazole resistance. Yeah, with the tinidazole, we did go up to the highest dose. It started working, and then the discharge just came back while she was on it. And the cost of it is high. One pill is $30 in Trinidad and Tobago, and you're basically going to be on a few pills for the day, right? So it was very expensive, and then it quickly started failing. And at that point, we just said alternative therapy.